Okay, I guess today we have uh, less number because of the people attending other educational activity. So I'm going to record it, and hopefully that people who missed it today can watch the record. So if you guys remember that care of sick baby is based on block of times, which include evaluate, then identify according to your evaluation, and then intervene or manage your identifying problem. And we said that we have initial assessment, which include whether the baby is breathing or not, what's the color, and what is the baby conscious, mean responsive or not responsive, and then treat accordingly. And after treat, whether you do CPR and regain of consciousness or you give oxygen and ventilatory support, you do your primary assessment, which include A, B, C, D, E, airway, breathing, circulation, disability, and exposure. We already talked last time about the exposure, and we reach here that it include evaluation and identification and intervene. So after the primary assessment, we go to the secondary assessment. And the secondary assessment is a focus history. And the focus history are called sample. Okay, so sample include S for sign and symptom, A, allergy, M, medications, and P for past history, and L, last meal, and then the events around the problem. And after we finish the focus history, we go for focus physical examination. And the focus medical examination is examining the area of concern, whether it's the chest or the heart or the abdomen or the brain or the accident or whatever was the problem. So again, because more people are joining, so now we are 8. So I'm going to go back and do summary to this session. The session is, if you guys remember that acute care of sick baby is a block of time. And this block of time takes 1 to 2 minutes. And it include evaluate certain questions or procedure, then identify problem, and then managing problem. The first assessment, we call it initial evaluation, which include the baby, whether the baby is breathing or not, whether the baby is color problem or not, and the baby is conscious, mean responsive or not. And then we shout of help for help and activate the alarm, the code for crashing baby or having cardiac arrest. And then we do, whether it's cardiac arrest, we do CPR until the baby regain consciousness, or provide oxygen and respiratory support. Once we finish this step, we go another assessment, including evaluate, identify, and intervene. We call it primary assessment. And the primary assessment include A, B, D, C, D, E that we earned. And now another assessment, which is evaluate, identify, intervene, called secondary assessment, and composed of focus history and focus examination. The history called sample, which include, it's an acronym, which is include signs and symptom, allergy, medications, past medical history, last meal, and event. And then we do focus physical examination, which include area of concern. And then after we do that, we examine the baby from the head to the head to toe evaluation. Okay? And remember, please, evaluation is primary assessment, secondary assessment, and then diagnostic test. Now, the primary assessment, any sign and symptom, we have to mention whether the baby have allergy or not having allergy, any list of medication, any past medical history, asthma, bronchitis, diabetes, hypoglycemia, heart failure, congenital heart disease, seizure, allergy, rare syndrome, metabolic syndrome, whatever there is a problem. And when the baby got his last meal or her last meal, and then what's the events around the the crash or the deterioration of the baby. Now, after we finish the the initial evaluation, primary assessment, secondary assessment, we go to the test. And the most important, when we have a sick baby, we do gas. Gas can be ABG, arterial blood gas, or capillary blood gas. Please don't do VPG. VPG means nothing. It's wrong sample. So don't do venous blood gas. Only benefit of venous blood gas is the pH when the baby has poisoning such as salicylate or aspirin. And also when there is diabetic ketoacidosis, we do pH. So when you do VPG, please use the pH. But if you want to read the blood gas, it should be arterial blood gas. And if you cannot get the arterial blood gas for any reason, we do capillary blood gas or CBG. We always need hemoglobin. We always need to measure the saturation by pulse oximetry. And when we do gas, please include lactate. Lactate are very important because it gives us an idea about the perfusion. If we can monitor the central venous pressure, and the central venous pressure, we monitor it if we can through the central catheter. So we connect the central catheter to infusion pump or infusion syringe. And most of time, the infusion syringe have the pressure gauge. Okay. We need also arterial, invasive arterial pressure monitor. We need imaging, whether X-ray or ultrasound. Most of the time, we need ECG or EKG, sometimes they call it. We need echo. And also we need, if we can, pulmonary function test. If the baby is old enough and can cooperate, then we need pulmonary function test. Okay, now remember please that there is a difference between arterial PCO2 and venous PCO2. So always the venous is higher, having a higher PCO2 by 4 to 6 millimeter if you want to read the PCO2 from the PCO2 from the venous blood gas. Okay. I don't want to discuss this. I think this is later. Now, when we deal with the respiratory system, we have to recognize the respiratory problem. And the respiratory problem, we have mainly two problems. We have hypoxemia, difficulty in oxygenation, or we have no moving air towards CO2 or hypercarbia. So we have ventilatory respiratory failure, and we have hypoxia, respiratory failure. Now remember, the arterial oxygen content are two types. Those dissolve in the plasma and thus connected to the hemoglobin. Connected to the hemoglobin, we call it oxyhemoglobin, and we measure it by oxygen saturation. And those dissolve in the plasma, we call it arterial oxygen saturation. And it's calculated as follow, is 1.36 times the hemoglobin concentration times the saturation. Okay, plus 0.003 times the partial arterial pressure. So the arterial oxygen content composed of two parts. Those dissolve in plasma, or the PaO2, and those connected to the hemoglobin. So when we have hypoxemia, or less oxygen, or decreased oxygen going to the tissue, or there is no oxygen in the blood, remember, it's two types. It's not only saturation that we measure it in SAT monitor, but also those measured in PaO2. And if you want to find the content of the arterial oxygen saturation, you have to multiply 1.36 times the hemoglobin concentration times the saturation you measured in the SAT monitor, and you add to it the content of the plasma, which is the partial pressure or partial arterial oxygen pressure. What are the signs? The early sign of the is tachycardia, tachypnea, nasal flaring, retraction, suprasternal, intercostal, and subcostal, agitation, because no oxygen going to the brain, anxiety, irritability, saying F words and becoming aggressive, pallor because of vasomotor instability, cyanosis when the carboxyhemoglobin become 5 grams, and then change level of consciousness and bradycardia. Now, with the current intensive care practice, we use NIRS. And because NIRS start to pick up hypoxia or near infrared spectroscopy, because start to check the hypoxia on functional level and on autoregulation level. So it happened before tachycardia. It happened before tachycardia occur about 2 to 6 hours. So it's a very good tool that I hope sometime we discuss it together, the near infrared spectroscopy. Now, impaired ventilation is inadequate ventilation. So whether we have collapses or whether we have obstruction or whether we have muscle problem, all can cause inability of the air to move in and out, and therefore not washing CO2 or blowing out CO2 and probably accumulating CO2. And it happened because inadequate ventilation. And inadequate ventilation, remember, as we've discussed, we're talking about the minute ventilation. We're not talking only about respiratory rate, and we're not talking about the tidal volume in each respiratory cycle. No, we are talking about minute ventilation, which is the result of a respiratory rate times the tidal volume. Most of the time, hypercarbia produce no symptom, but it causes only acidosis, and then acidosis affect everything. We can measure the CO2 in the artery, in ABG. We can measure it in VBG. We measure it in the capillary or CBG, but also we can measure it in the CO2 in the exhaled gas. And there are two measurements of exhaled gas. We have to have something called capnography, which is a graph showing the CO2 continuous, or we measure it one time at the end of inspiration, at the beginning of exhalation, or called end tidal CO2. We also sometimes measure the CO2 as something called calorimeter. So we put some device on the ETT, and then once there is change in the color with ventilation, whether the hand or the ventilation, the color change between yellow and green, and that's mean there is CO2, and this gives us an idea about whether we are in the lung or not. So measuring the CO2 can be in the blood gas, which is either arterial, venous, or capillary, and it can be in the exhale gas. It can be capnography, end tidal CO2, or calorimeter. Any question? Questions?
Dear doctor, can we say the impaired oxygenation is the most common cause of respiratory failure? Is more common that the
can we say?
Yeah,
no,
I mean,
we cannot say that, but you're some sort correct, but not because it's more common, but it has more clinical effect than hypercarbia, and therefore it's been noticed more. So when you go to the emergency, most people, they will check saturation. So when saturation deteriorate, they say respiratory failure. But most of people don't check blood gas. So, and then they don't look to the CO2. And that's the reason why you don't see it frequently. Not because not common, they usually go together. But once you start to measure it, you will see it is very common. When you you have policy and you care and do frequent blood gas, you'll see it is a common problem actually.
So we have to check it more.
Yeah, blood gas, you need to check the blood gas, or you should have a capnography. Yeah. Any more questions? Of course, we'll show you the capnography, we'll show you the calorimeter, we'll show you all these, inshallah. And I hope next week we can meet at some point. You guys did not decide when we will meet, but I hope we will meet soon. Okay. Now, what are the signs of inadequate ventilation or increasing CO2? You get tachypnea, you also get nasal flaring, you get also agitation and anxiety, and also because remember, CO2 can change, and that's why when you take alcohol and alcohol goes to its original, which is the water, the fat, and the CO2, and once the CO2 in the body, you get you get the mood effect or the brain effect or change consciousness. So also CO2 change the consciousness. Now, so this is a very comprehensive slide. Does include everything related to respiratory deterioration in pediatric. Okay. So what are when the baby comes in a respiratory hypoxic or ventilatory failure, then these are the problem. First is we have low oxygen in the atmosphere. For example, you have high altitude. So once you get high altitude, you have decrease in the pressure, and therefore you get less oxygen, and you get this decreased oxygen. So the treatment when you have the E or the exposure that the person was in a high altitude, you just need to give oxygen. And remember the human right, the oxygen should be, you guys remember the three? When we give oxygen, what we should do? Do you remember it?
Should be
When we give
humidified,
it humidified, واحد
Heat.
اثنين
heated,
heated ثلاثة blended
blended, yes, with
blended
air.
with air. So heated, humidified, and blended. Okay, remember, please don't give direct oxygen. Okay, so that's why each hospital, they should have air. دكتور زهير عنده سؤال وما دا يجاوبه. You can type Dr. Zuhair, or you can ask me the question on WhatsApp if you want. But you are unmuted, so just I'm gonna. Okay. You are muted. Can you unmute yourself? Dr. Zuhair? Yes.
Asad Sma?
Hey, yes, I can. I can hear you. Go ahead.
Probably later I can. The two
Okay.
questions. The two questions, حقيقة, about the signs and the symptoms of hypoxemia. How do you explain? How do you explain the survival and the growth of those patients with cyanotic congenital heart disease for many years, and they have no such symptoms physiologically? I would like to know the.
We're not talking about chronic hypoxemia or chronic.
Second,
yeah, we're talking about acute
for
hypoxemia.
Yeah, acute hypoxemia, right?
Yeah, so chronic hypoxemia.
So go ahead, please.
Yeah, chronic hypoxemia, the body will react to it, and the body will get used to it. It will start to compensate, but it will take from the growth of the baby. So you'll have first the performance of brain goes below, so the baby might have intellectual problem. Second, the baby will not grow because they use more calories, and there is not enough oxygen to the brain and to the tissue, and the baby will not grow. That's the reason when you have a chronic hypoxia, then the baby, the presentation of chronic hypoxia is having a brain problem, such as intellectual disability, such as delay language, such as even sometimes behavioral problem, such as you get decrease the brain substance, or what we call it here in Iraq, brain atrophy. Okay. And the word brain atrophy, you only hear it in Iraq. I never hear a disease called brain atrophy like as much as in Iraq. And
So
also the tissue can affect it, and that's why they got, most of the babies that I see now with heart problem, congenital heart disease, are actually not gaining weight. And that's the reason when you get chronic hypoxia, you need to give higher calories and less fluid. But when we're talking here, we are talking about acute hypoxia, not the chronic hypoxia. Okay, so that's Dr. Zair, one question. What is the second?
Right. ده يقطع الصوت دكتور يحيى.
قطع صوتي لو صوتك؟
صوت. What about
صوتك.
everybody?
Oh, okay. It's okay. We can discuss your question later. Let me continue until, and then we can ask your question later. Or answer your question later. So the first, when you have oxygen decrease, it's because of altitude. Second, the other problem that we will face is what we call it alveolar hypoventilation. That means there is no air going and coming back from the alveoli, and therefore we are not washing CO2. So when this happens, because there is no order from the brain to the respiratory symptom, and that occur when you have CNS infection, or when we have traumatic brain injury, or when we have intoxication, okay, or sometimes we don't have good ventilation when we have neuromuscular weakness, okay, such as a nerve problem, such as a neuromuscular problem, or even muscular problem. And also when we have apnea or hypopnea, or problem with, and that's what we call it with controlled breathing problem. Once we don't have less ventilation, your CO2 goes up. And that's what we call it hypercarbia. And once the CO2 goes up, it displaces oxygen. And that's why you will have decreased alveolar and oxygen tension, and then you end in hypoxemia. So you'll have low oxygen in tissue. So what the solution here is to restore the ventilation. So either you give non-invasive or invasive ventilation, and if there is no response, you give oxygen supply. Now, remember, please, I'm not against giving oxygen. You have to give oxygen when the human being need it. But if you continue to give oxygen more than 30% for more than like 15 minutes or 30 hours, that means you have a problem either in you or in the baby or in the machine, because you have to escalate the support so you are able to decrease the FI2 need. So the first problem is the environment have no oxygen. The second, we have ventilation problem. The other, diffusion defect. So the gas is not exchanges at the level of the alveoli, because the barrier or the structures or the membrane of the exchange area are changed. When you have pulmonary edema, you have fluid in the alveoli. Once you have fluid in the alveoli, you have many problems. The first one is you neutralize the surfactant. The surfactant are fat, and the alveoli are full of the fat. When you have water in there, the amount of the fat will be diluted. Okay, and then you have the other problem that causes pulmonary edema, and pulmonary edema when you have water inside the alveolar wall. But also you can have the fluid in between the alveoli, or what we call it interstitial pneumonia. Okay, also when the alveoli start to secrete protein, or what you call it alveolar proteinosis. There are many diseases caused. That's problem. And once we have diffusion problem, we have impaired movement both of oxygen and CO2 between the alveoli and the blood. And then we have the hypoxia, and then we have hypercarbia. And usually the treatment is most of the time resolved by CPAP. And please remember, CPAP does not cause pneumothorax. Please remember this, CPAP does not cause pneumothorax. Just always repeat it when CPAP and PEEP does not cause pneumothorax. Just keep repeating it with yourself. The pneumothorax is disease of change. Disease change of time or change of place. So if you have a lung and you have different pathology, such as meconium aspiration, you have area of atelectasis, you have area of good ventilation, then there is risk of pneumothorax. When any problem, any parameter during respiratory cycle that change in time can cause pneumothorax, such as PIP, such as respiratory rate, such as inspiratory time, okay, such as tidal volume. All these are risk of pneumothorax. But PEEP is actually a safety for pneumothorax. So when you have edema and there is a fluid and the surfactant neutralized, then the alveoli start to stick. So the only reason way to open it is to give a pressure. And this pressure usually by CPAP. And if the CPAP it does not help, then we go to high frequency. And if the ventilation. And if the ventilation didn't help, we go to high frequency. Okay? So that's very important, guys, to remember. If the high frequency didn't help, then we go for ECMO. I don't have ECMO here in Iraq, but that's how it goes. Okay? There is, so the first problem in the respiratory is low atmospheric O2, alveolar hypoventilation, diffusion problem, and then ventilation perfusion mismatch. Now, please remember that we have 3 areas in the brain. The uppermost part, so if you are standing, will be the upper part of the lung, but if you are sleeping, lying on your back, it will be the anterior part of the lung. So we have ventilated part, we have perfusion part, and we have matching part. So the ventilated part is upper part of the lung. The perfused part is the lower part of the lung. And the match part of the lung is where the ventilation and perfusion are both are good, is the middle part. Okay, so once the perfusion start to move from down to up, to the middle to the up, you get high perfusion. And once the ventilation goes down, then you get high ventilation, and you have what we call it ventilation perfusion mismatch. So when we have, I'm gonna stop sharing and show you something. Okay. Do you see my hand?
Yes.
Okay. So imagine this is alveoli and this is blood vessels. You get it? So the alveoli match the blood vessels. Okay? So once you start to have atelectasis, you get small alveoli, but still normal blood vessels. So this area is exchanging because there is match. This area is not exchanging. The blood will come and go back. So the gas will go in. So you have a blood that coming to the alveoli, not getting the exchange and going back. And that's what we call it hyperperfusion. Okay, is that clear? Is that clear? What perfusion ventilation mismatch? So when you have the alveoli stick or having a fluid inside, whether this fluid is protein or clear fluid, all causing the surfactant to be lost. When the surfactant gets lost or neutralized or diluted, the alveoli will stick. So the baby will start grunting. Okay, so you get pneumonia, you get some problem. Atelectasis, you get some problem. Or if there is RDS, ARDS, such as inhalation of fumes or crush injury, also cause same problem. Asthma, you get obstruction, you get same bronchiolitis, foreign body, all you get ventilation perfusion mismatch. Because there is area where there is blood coming, but we are losing the alveolar bed. So the blood will come and go back without having enough oxygen and not sending the CO2. So you get decreased oxygen and increased CO2. So the solution to that is you increase PEEP. See? So the good ventilator is to provide good PEEP, less inspiratory time, less PIP. That's the good ventilation. Okay? Now you also have to supplement oxygen, but also remember you have to make the baby happy. So you need to provide good sedation and good analgesia. Okay? And the other problem is shunting. You know that in the right side, the blood is coming from the body and has less oxygenation. While the left side, the blood coming from the pulmonary vein from the lung have better oxygenation. And if there is opening between right and left and the pressure on the right is higher, whether all the time or in a certain cardiac cycle, the blood will move to the left and will be mixed. And that's why you get right to left shunt. It's example of cyanotic congenital heart disease, or if there is vascular shunt. And it will happen the same because there is blood going to the body, have less oxygenation. Despite the lung has no problem, but it's the same problem, is the blood coming back to the body without oxygen. So the blood without being oxygenated. So exactly, shunting is like ventilation perfusion mismatch. So the only solution is to correct the defect or you provide oxygenation. Okay, but remember when you provide oxygenation, the three principles, do you guys remember them? The three principles of giving oxygen? You guys remember them?
Yes,
Yes.
humid, blended, and warm.
Great. So heated, not warm, heated, humidified, and blended. Very important to remember this. It's a human right. Now, there is what we call it airway resistance. Remember, please, resistance and compliance. Don't forget them. Resistance is airway. Compliance is the lung, is the alveoli. So don't mix between resistance, and we will talk about it when we take hemodynamics, pulmonary dynamics, and loops and graphics. We will discuss this in details. But remember that when we say resistance, we're talking about the airways. When we say compliance, we're talking about the alveoli. Okay, so airway resistance is when the size of the airway changes, either because of bronchospasm, constricted, or because of inflammation. The inflammation can be in the endothelium, but also it can be in the wall. But also it can be mucus inside the airway, or it can be outside the airway as a mass. Because the flow is turbulent, become turbulent, and we'll talk about what's turbulence later. So, because remember, whenever there is turbulence of the flow, the human being will increase the rate. Whenever the flow is laminar, do you guys know what is laminar flow? Anybody know what is laminar flow? So laminar flow is when you look at the river, if you've seen river, the water in the middle move very fast. And as you go to the banks, to the periphery of the river, you go slow. That's what we call it. It's like a bullet. So in the middle, the bullet is fast. When it goes to the periphery, it slow down. So laminar flow is very fast moving in the middle and goes slow once you go, until at the banks you get turbulence of the flow, or and sometimes you get swirls. So resistance is inversely related to the fourth power of the airway radius. So imagine when the airway increase in the size, how the resistance will change. So the fourth power, each centimeter, like if you change 1 millimeter times 4, so you get 4 in a 4 change, if you 1 change in the diameter, you get 4 changes in the resistance. And remember that when you get more inflation, resistance will decrease. Now we will talk about resistance and compliance once we talk about ventilation. The compliance is the distensibility or the stiffness of the lung. So it is being controlled by pressure and volume, while the resistance is in the airway, and it's the relation between the pressure and the flow. So flow and the pressure, you get resistance, pressure and volume, you get compliance. Pneumothorax, because air in the around the lung change the negative pressure. Also, when there is fluid around the lung, change the negative pressure. And any mass extrapulmonary will all decrease compliance because it decreases the volume. Pneumonia and lung inflation cause atelectasis such as ARDS, fibrosis, and pulmonary edema, all cause atelectasis of alveoli and decrease volume. So anything interfere with volume will change the compliance, whether it's intrapulmonary or extrapulmonary. Okay. So this is from the pediatric advanced life support. So first, remember that we said that dealing with acutely ill child is evaluate, identify, intervene. And remember, we said that we have initial assessment, we have a primary assessment, and we have secondary assessment. So in the first thing, when we decide whether we have an airway problem, so we just need to say that airway is maintainable, not maintainable. So open, maintainable, not maintainable. And when we say maintainable, that means we can open the airway with some simple maneuvers, such as chin lift and head tilt. When we say not maintainable, mean we need adjunct airways. So that's our A. Second is respiratory or breathing. In breathing, we said we talk about respiratory effort, whether increasing or decreasing, and a breath sound. So for the airway, whether it's upper airway, whether it's lower airway, whether it's lung disease or disease of controlled breathing, it's the same identification. Is it airway open, maintainable, not maintainable? In respiratory rate and effort, in case of upper airway, lower airway, and lung tissue disease, most of the time, the respiratory effort is increasing. But in the disordered or controlled breathing, the work of breathing can increase, can decrease, and can be normal. Also, we said when we measure the breathing, the B, then we check the sound. So if it's upper airway obstruction, it's usually inspiratory, okay? And you can see hoarseness, you can see stridor. If it's lower airway problem, we hear wheeze, and it's expiratory, and there is a prolonged expiratory phase. While in lung tissue disease, you get grunting. Do you see the difference between grunting and increased work of breathing? Now, grunting, remember, grunting means there is atelectasis. You can also hear crackles and, of course, decreased breath sound. Now, when we have disordered controlled breathing or apnea or hyperapnea or hypopnea, you usually don't have sound. So the sound usually normal. The air movement. Now, when you have upper, lower, or lung disease, all the air entry will be either poor or decreased or even absent, while in the disordered controlled breathing will be normal. Now, the heart rate in the respiratory problem, you can get tachycardia or bradycardia depending on the phase. Skin, when you have respiratory problem, you get either pallor due to poor perfusion or or cold skin, or you can get cyanosis. Level of consciousness, in the beginning, you get an anxiety, you get agitation. The reason is because of high CO2, low oxygen. Once the brain starts not functioning, you get lethargy and unresponsiveness. Temperature are variable in all the diseases. So these are a summary of A, B, C, D of the primary assessment of respiratory problem. Now, when and how respiratory disease goes to respiratory failure. So when we have a respiratory disease, usually our air are open or maintainable. Once we get respiratory failure, usually in airway or a disease, the airways, if there is respiratory failure due to airways, then usually the airways are not maintainable. When we have a breathing and we have a respiratory, usually we have tachypnea. But when we have a breathing problem and it's a respiratory failure, usually we get bradypnea or apnea. Both respiratory disease and respiratory failure, we have increased work of breathing. But the effort at the beginning, when we have a respiratory disease, the effort will be decreasing. Once we get respiratory failure, the effort will be decreased until we stop and got apnea. When you have a respiratory disease, we have good air movement. When you get respiratory failure, we will have poor or absent movement. For B, sorry, this is not B, this is C. This is a mistake. Just let me check it, change it. Sorry about that. Now, for the C and respiratory problem, when it's a respiratory disease, we get tachycardia. But when we get respiratory failure, we get bradycardia. When it's respiratory disease, we are impaired, but when you get respiratory failure, you get cyanosis. For the D, or level of consciousness or disability, at the beginning, you get, when you have a respiratory disease, you get anxiety and agitation, but once you get respiratory, you get lethargy and unresponsiveness. And while the E, and the E is the temperature mostly we're dealing, exposure, usually the temperature are variable in either respiratory disease and respiratory failure. Okay, so I will stop at the management here for respiratory disease. Or you guys want me to continue few more minutes? Should I stop or continue a few more minutes? Do you want me to stop here?
Yes, please.
ده يقطع هوايه
صوتي ده يقطع؟
الصوت ده يقطع هوايه ما ادري for the other
صوتي ده يقطع يا جماعة؟
I don't know
لا
the same
لا
No.
لا لا صوتك زين صوتك زين ما دا يقطع
لا عادي،
يمكن
عندك مشكلة
مشكلة
دكتور زهير
جهازك
أنت.
دكتور
يمكن
لا
دكتور
أنا
زهير
عندي
أنت عندك
مشكله
مشكلة.
بالنت عندي مشكله بالنت
إيه
إيه
يمكن
لا عندك مشكلة أنت دكتور زهير. مو أنت يمكن ماخذ إنترنت رخيصة دكتور زهير، شوي أصرف فلوس يعني.